Hello, everyone. My name is Antonia Reimer-Taschenbrecker. I am a pediatrician and dermatologist working in the EB Center in Freiburg, Germany. And for the last couple of years, I have focused on growth and nutrition in EB. In today's talk, I want to give an overview on nutrition and on the nutritional situation in people with EB to show you some potential pitfalls and solutions for RDEB nutrition and implications for clinical management and life. So nutrition is defined as the process by which an organism absorbs and utilizes food substances. And that includes nutrients that are essential for growth, but also for the maintenance of the organism. We have various functions of food. And the three main functions are to provide energy, to provide building blocks for enzymes and structural components of the body, and also nowadays to give pleasure. How much energy and food does the body need? This is calculated by the resting energy expenditure. So that means like the baseline energy level the body requires to function. And this depends mainly on the age of a person, his or her gender, and body size. Additional needs can come from sports, when somebody is very physical active, from wasting diseases, from inflammation and wounds. And you already see the connection to EB there. And it's always important to have a balance between the requirements and the actual food intake. To measure nutrition and the outcome of nutrition, we have very simple measures like weight, height, and the body mass index as a calculation of the two. There are more complex measures, but let's stick to these three for the time being. The World Health Organization has defined these very helpful ranges to tell us what is healthy weight, underweight, overweight, and obesity. When we don't have the balance between requirements and intakes, we either have the situation of undernutrition with underweight, which causes cachexia, a status where the body kind of uses up its own energies, like destroys the muscle to provide energy. It can lead to a delay of puberty and also to osteoporosis. And then on the other hand, when there's too much intake to meet the requirements, we have overnutrition, which will lead to obesity. And this causes many problems such as with the joints, with high blood pressure, diabetes, and many more. So to have the optimal nutrition is necessary for optimal growth and also for quality of life. In nutrition, we have two main players. That is on the one side, the macronutrients, and then the micronutrients. There are three main macronutrients: the carbohydrates that provide a rapid energy supply, and we differentiate between simple carbohydrates, the sugars, and complex carbohydrates. And while this is a very good supply of energy, the blood glucose changes can be very rapid with simple sugars, and also sugar can promote caries. The second macronutrient is fat, which is a very rich source of energy. It has more than double the calories of carbohydrates and is also important to transport fat-soluble vitamins. And then the third macronutrient are proteins, which consist of amino acids. And these are like the essential building blocks of the body. They're important for cell maintenance, for muscle buildup, for wound healing. If no other sources are available, or too little carbohydrates and fat, then proteins will also be used to generate energy. And this can also be proteins that are already in the body, like in the muscle tissue. In the group of micronutrients, this is a very large group, so I took a EB-relevant selection of 4. One big player is iron, which we need to build up hemoglobin. And if there's too little iron, the result is anemia. And iron deficiency is very common in EB through blood loss via wounds, low intake, probably also an impaired intestinal resorption, and inflammation that additionally consumes iron. Then we have the vitamin D, which is important for bone formation, for wound healing, and the immune system. And interestingly, the human body can produce vitamin D by itself, but that is not even sufficient in skin healthy people and not at all in EB people. Zinc is another important micronutrient, important for wound healing and the immune system. And selenium has very important adjuvant functions in metabolism processes in the body. So, what is the nutritional situation in EB patients? That is not possible to say in one sentence and not even in a talk of 15 minutes. But to give you a quick overview, patients with different EB types have very different nutritional status and require different requirements. Let's have a look at EB simplex. We see that in children with EB simplex, they may struggle to gain weight, especially in the severe type. But adolescents and adults are actually at risk of obesity. You see it in this woman here. And we have recently shown in our Freiburg cohort that after the age of 10 years, the rate of obesity goes high, and up to 60% of our patients with severe and localized EBS are actually overweight or obese. The main clinical findings in EB simplex in adults are painful blisters, especially on the soles of the feet, and plantar keratoderma, and that is associated with pain, local infections, overweight, and reduced mobility. We have envisioned this as a vicious cycle where you have the pain on the feet through the skin findings that causes you to rest. And then if you keep eating as usual, the weight and BMI will go up, and the increased body weight will actually increase the problems on the feet. And so it goes on and on and on. And a significant proportion of our patients actually require a wheelchair some of the time. So we have a reduced energy need in EB simplex in adults due to physical inactivity. In junctional EB, we have potentially additional energy needs due to inflammations and wounds on the body. In severe junctional EB, so the former Hurlitz type, the infants suffer from general weakness and often require tube feeding. In junctional EB intermediate, many individuals show nearly normal growth. But those children that show underweight and chronic wounds from early on are potentially at risk for a lethal cause and should be monitored very closely. In RDEB, we have the situation of a very high wound burden and inflammation, as you can see here in these patients. And this leads to an increased energy demand, which is actually similar to that of burn patients. Also in RDEB, we have a significant mucosal involvement. And this results in pain and slow eating, swallowing difficulties, and constipation. This also means that food that would be very qualitatively good to eat with regards to the macro and micronutrients in it, for example, meat, is difficult to chew and swallow. In our Freiburg cohort, we have shown that the growth in RDEB is severely impaired from early on, and that this growth deficiency correlates with nutrient deficiencies. And also, puberty may be delayed in RDEB with a bad nutrition. This nutritional compromise in RDEB can be quite easily grasped through growth percentiles. We have calculated these for our Freiburg cohort, and these are available for download, open access, for clinical use as well, to follow your patients. If you like to use them, please feel free to download them. And I quickly want to show you that this boy here, who would be around the 3rd percentile of healthy boys, these are the green lines here, is actually in the middle range of an RDEB boy. And you see here this, the arrow shows that the nutritional compromise the weight that doesn't follow the normal percentiles of healthy children, that sets in the second year of life here. So that's really the point where we need to start to do something. There are other tools as well to assess nutrition in RDEB, such as the Think tool, a questionnaire that was provided by the British group and can be downloaded from DEBRA UK. So let's have a look at some potential pitfalls and solutions for nutrition in RDEB. The main 5 pitfalls that I see are long-lasting meals, and still you have too little uptake, and loss of pleasure of eating, carriers, constipation, osteoporosis and osteopenia, and late substitution of nutrients. So these long-lasting meals, what can we do? Well, it's obvious you need to avoid hard crusts, but there are more innovative approaches than just cutting off the crusty edge of the bread, like the smooth food that was introduced at the DEBRA International Congress 2018 in Zermatt, which is very innovative and quite delicious, I have to say, but also quite a hassle to make when you have to do it every day. So it's a good solution for sometimes, but not for every day. But an everyday solution can be fortified supplementation through high caloric drinks and powders that can be mixed into food, and also adding oil, butter, and cream to food. This should always be complemented by individual consultation and planning through dietitians. And it's good to calculate the actual energy requirement. And that was suggested, and I think it's a very good suggestion by the British group, to be around 150% of energy requirement of the chronological age. So it's obvious that you can't do that with a normal meal in an EB speed of eating. So we need this supplementation, or in case of stenosis, esophageal stenosis, esophageal dilatation should be performed, and also gastrostomies should be considered early, and if they are put in place, they should be used for regular tube feeding. So for the carriers, it would be good to allow for sugar breaks, although I know that sugar, of course, is the quickest supply of energy, and oral hygiene and regular dentist visits are key, as also summed up in the recent clinical practice guidelines for oral health care. Constipation should be treated early and consequently. In our center in Freiburg, we mainly use macrogol and lactulose for that, but some patients also choose to use household remedies such as flax seeds or linseeds, which can work quite well in many people. For osteoporosis and osteopenia, it's really key to prevent this. So if we optimize nutrition from early on through uptake of enough calcium and substitution of vitamin D, that will be helpful, and also to stay mobile. So physical activity actually enhances the bone composition. And instead of doing a late substitution of nutrients, when you wait for deficiencies to be visible in the lab, we should always do an early substitution. And the suggestion from our big cohort study is to do that from the second year of life onwards, at least with iron, vitamin D, zinc, and selenium. So to sum up, the implications for clinical management are to include dietitians in interdisciplinary treatment from early on, especially so in RDEB and EBS, and in some junctional EB patients as well. We should monitor especially the children very well, at least by taking the weight. And I invite you to use the EB growth charts. Maybe you also find them useful for your patients for clinical follow-up. In EB simplex, we have to take care to prevent overweight and immobility that results from it. And in RDEB, the nutritional intervention should be begun very early, and the risk of overdosage appears very low. We haven't seen that in our entire cohort, but it would be good to have prospective studies on this, of course. And an early gastrostomy may be of benefit. So I thank you for your attention. I'm looking forward to your questions. And I thank everybody who's working with me in Freiburg, my team. Thank you.